Hello, everyone. Thank you for joining us and welcome to today's webinar, OCR HIPAA Enforcement Shifts, presented by MEDITOLOGY Services, hosted by the Minnesota HIM chapter and sponsored by Trinisys. If you would like to be a speaker or sponsor for future Minnesota HIMS hosted webinars, please reach out via their website at mn.himchapter.org. My name is Kayla Triggs. I'm on the MEDITOLOGY Services team and will be moderating today's session. We'd like to make today's webinar as interactive as possible. So before we get started, I'd like to go over a couple of items so everyone knows how to participate. You'll all have the opportunity to submit questions to either myself or today's presenters, Ryan Freeman-Jones and Bethany Page, by clicking on the questions pane of the GoToWebinar control panel. You can submit your questions at any time throughout the presentation. The presentation portion should take roughly 45 to 50 minutes, which will leave us with about 10 to 15 minutes for questions at the end of the session. If we happen to run out of time, we reach out to address any unanswered questions during our post-webinar follow-up. Each of you will also receive a follow-up email with a link to view a recording of today's session. Now let's get started. OCR enforcement activity is up. OCR completed proactive audits and reported significant gaps in compliance with HIPAA mandates, including risk analysis and risk management. OCR also implemented a new structure for civil monetary penalties in 2019. Today, you will hear how coveted entities are responding to OCR scrutiny by updating security risk registers, business associate inventories, breach notification practices, and more. Ryan Freeman-Jones is an experienced HIPAA security and privacy officer and an expert in healthcare information security and compliance. He directs MEDITOLOGY's practice and leads the firm's West Coast office based in San Diego, California. As a former HIPAA security and privacy officer, Ryan has extensive knowledge in compliance requirements such as HIPAA, HITECH, PCI DSS, NIST, ISO, and other regulatory and risk standards. He has been HIPAA certified since 2016. Ryan teaches an IT risk management course at Valparaiso University in Indiana that is focused on IT governance and compliance. Ryan was also one of the chief architects of the MS in Cybersecurity program at that university. Bethany Page is an experienced compliance and information security leader focused exclusively on healthcare information risk management. Bethany advises healthcare clients of varying size and complexity in areas of IT, privacy, security, and compliance. She has in-depth knowledge of security technology frameworks such as NIST, HITRUST, ISO, HIPAA, HITECH, and PCI. Bethany also has hands-on security experience serving as CISO for MEDITOLOGY Services and Coral Technologies. She has deep experience working with healthcare entities across the country to assess and respond to OCR HIPAA regulatory requirements. First, just a quick word from our sponsor, Trinisys, then we will begin the presentation.
Thanks, Kayla. This is Pat Regan, Director of Business Development for Trinisys. Trinisys is just proud to be a new corporate sponsor for Minnesota HIMS. We feel privileged to bring tangible value during these trying related to the archival and centralization of legacy data. Our solution is immediate and substantial cost savings, enables providers and staff productivity, including virtual access, and improves comprehensiveness and quality of historic patient information, as well as providing updated and advanced data security. Trinisys has been in business for 16 years, owns all of our technology IP, employs all of our software development team, no subcontracting or offshoring, and we've been fortunate to have grown primarily from customer reference. We've served some of the most prestigious national and regional health systems, which includes academic and specialty organizations. We welcome an opportunity to provide a no-cost analysis for your legacy health and or financial system environment. Again, I'd just like to thank the Minnesota HIMS chapter for this opportunity to introduce Trinisys. Thank you.
Great, thank you, Pat, and thank you for the introduction, Kayla, and welcome everyone this morning. I certainly appreciate you all spending the time here with us. Before we get started, I do want to go ahead and introduce MEDITOLOGY services and everything that we do here at MEDITOLOGY. Starting out with that, MEDITOLOGY services is a information security and privacy firm specializing in healthcare. So we work specifically with healthcare clients, anywhere from small physicians practices all the way up to larger business associates, payers, and health systems. One thing of note that I want to share and quickly to our horn is our continued kind of ranking in the class research ranking. And so MEDITOLOGY for the past 2 years was ranked best in class. Some additional things about MEDITOLOGY and something I think important for today's discussion is that we are part of the OCR's expert witness team as a firm and have provided advisory services to them. From a leadership standpoint, our firm leadership are both operational leaders having experience being information security and privacy officers in healthcare, as well as vast consulting experience in healthcare. We have numerous clients coast to coast and have been selected as has advised the ONC and HHS in the past. Moving on, a little bit more about MEDITOLOGY and really our presence. We are a coast-to-coast firm with offices in the East Coast and West Coast. So something that we wanted to point out here. Moving to the next slide, which is the agenda for today. So why everyone joined today's session. So we're really going to discuss with you some of the enforcement recaps that we've seen with the OCR in the past couple of years, some of the results from that. Then something you all might be very interested in, some of the new penalty structures that were announced last year from the OCR. Then of course, some of the changes or temporary changes with enforcement from the COVID-19 situation we're currently dealing with. And then lastly, of course, lessons learned and what we've seen from enforcement and our experience there. And then of course, time for question and answer. So I want to start today really with giving you some insights into recent enforcement recaps and some highlights from some things that we've seen in 2019 and thus far in 2020. So the key takeaways on this slide, there's quite a bit of information here. Key takeaway number one, HIPAA enforcement is still ongoing. The OCR is actively enforcing and taking, up until the current COVID situation, taking up cases and that sort of thing. And so you can see here, there are several key themes that are present. Theme number one, risk management, risk analysis. Those two sort of things are really on the OCR's radar. And so you'll see across a lot of the items here, a lot of the enforcement recap here, risk analysis being a big piece of that. Another big piece is really breach response, reporting, incident response. Still noticing a lot of breaches going unreported, unnoticed. So that's also something that it is being called out here as well. And then as recently, again, as March of this year, there was a fine handed down for a single practice, again, around that risk analysis. And so that's something really critical that we're going to discuss in more detail here throughout this conversation. So moving on into some of the highlights from breach numbers, you can see in this list, the key takeaway is that breaches are still happening. They're in fact on the rise in healthcare, and again, kind of ensuring that adequate risk management, risk analysis, breach detection, incident response, those sorts of things are a key focus area. So I'm going to move on and really jump into the meat of the new OCR penalty structure that many of you may be aware of. So really looking at a timeline of kind of HIPAA enforcement, I think one of the key takeaways here is HIPAA has morphed and matured over time from its inception in 1996. And there have been kind of several iterations of tweaks to either the rule or how enforcement is administered by the OCR. And so that is going to show as we learn more about our environments in terms of information security, privacy, HIPAA alignment, the government is responding to realities on the ground and making changes to better the enforcement program. And I think that's really a key takeaway here. The most recent one being with the new cap limits that were introduced in 2019. And so I'm going to go, I guess, a little bit into more detail about these cap limits on the next slide here. So I want to jump into the revised OCR penalty tiers. So as many know, there's kind of 4 penalty tiers ranging from, more minor, I guess, incidental issues that there was no knowledge of, that sort of thing, all the way up to willful neglect, issues that have not been corrected, persistent systemic issues in the organization. And you can kind of see here from a summary, previously the annual limit for each tier was $1.5 million. And now with the 2019 changes, the annual limits have changed based on the tier. So tier 1 being reduced from 1.5 million annual limit to 25,000 and going up from there. So I'm going to talk a little bit about why that is and some of the things that we're seeing from OCR penalties. But the key takeaway here is the reductions in tiers 1 through 3 are really geared around incentivizing organizations that do have strong operating and well-documented information security programs in place. So as an incentive to stir that. So moving on here, I do want to go into a little bit more detail about the changes per tier and what they mean and why they are. So starting with tier 1, this is the kind of the no knowledge tier. So this is really around organizations perhaps not knowing that there was a violation or that they violated, HIPAA in one way or another. And that if they had even, been able to demonstrate that they had done due diligence, that the violation, they still would not have known about the violation, I guess is what I'm saying here. So some examples of what that really means. If your compliance team or audit team, was made aware that an employee shared PHI with a friend, outside of work, that's an unauthorized disclosure. That would be an example there. But at the time of that incident, the organization had strong practices in place, things like strong risk management protections, training processes, other controls in place that could prevent and detect that disclosure. And then, through all of that, the organization was still unaware of the violation and would not have known about the violation at the time of the incident. That's really that tier 1, that no knowledge tier. So you're doing, some of the things that you need to be doing. You have the programs in place, but there is no way for you to know about that. So moving on to tier 2. Tier 2 is reasonable cause. So here it's a little more escalated here. So here it's really, you should have known about it. So in the last year, you might not have reasonably been able to know the violation took place. Here, reasonably, if the violation took place because there is circumstances that were unreasonable for the organization, despite the fact that you're able to conduct your normal business. That's really what is being discussed here. So, for example, if your organization conducted a risk analysis or some pen testing, penetration testing, ethical hacking, that sort of thing, and identified a high-risk vulnerability, maybe your patient portal had some issues with some third-party management, or perhaps one of your vendors was doing something that you weren't aware of. From that analysis, the results are reported to your compliance and leadership teams. The organization was able to authorize
All right, I think we have a little technical difficulties from Ryan. So as we covered tier 1 and tier 2, tier 1 being no knowledge, tier 2 being reasonable cause. But as we get into tier 3 here, really getting into willful neglect, and but willful neglect that was corrected. So the violation was a result of the organization's conscious intentional failure or reckless indifference. But the organization corrected the violation within 30 days of discovery. Again, this tier structure is getting more into the upper limit. So the annual limit for this penalty is $250,000. And some examples would be, I know shared logins are still found, so generic accounts. So an example around having a single shared login account and password for all employees to access a clinical billing system. But again, that it was eventually corrected. Or for example, maybe that generic and shared account was identified during a risk analysis as a high risk finding, but it did not go corrected within an appropriate amount of time. And again, an appropriate amount of time would be deemed by the organization. So we'll get into the importance of a risk register, and that being a living and breathing document, and the associated remediation plan and time frame. So if it was documented in your risk register, it's a high risk, but there was a remediation date and that slipped by, that might fall into the willful neglect corrected within a reasonable time frame. All right, just checking to see if Ryan is back. If not, I'll cover the next slide.
I'm back. Sorry about that. I'm not sure what happened, but let's continue. So with tier 4, willful neglect and issues that are not corrected. So here, what we're really looking for here is if the organization should have known, that an issue could have occurred. Number one, that the risk was there. They should have known, and they did not do really anything about it from a program level to detect, address, report, and mitigate the issue. So this really comes to conscious, intentional, reckless indifference to the obligation to comply with HIPAA. So some examples here, blatantly posting records online. That shouldn't happen. That's something that should not take place. Or something as simple as having authentication for your medical records, a control that that has been well established as a requirement for secure record sharing, that sort of thing. And so some additional examples, if the organization has a shared logon for all employees. So if you have a billing system and everyone has the same username and password for that billing system, that would be willful neglect, something that should not be happening. Another thing here, so with respect to risk analysis, something that we are going to keep mentioning and bringing up throughout this conversation. If an organization has conducted their risk analysis on an annual basis, identified that shared password was there as a high risk, and they have that in their risk analysis year after year after year and have not taken corrective action and tried to address that issue, documented a corrective action plan, then that would be willful neglect. So those are some things to think about across all of the tiers. It goes from if you couldn't have reasonably known about the issue all the way up to if you knew about it and you didn't do anything about it. That's how the tiers are organized. And so, really there, then the key takeaway is risk analysis is mission critical to sustaining HIPAA security and privacy. If you don't know what your risks are, then you can't manage them. And that's the issue here. So as I mentioned previously, kind of, overviewing the changes, what the OCR wanted to do is, I guess I'll say reward or incentivize groups to do thorough risk analysis, document those risks, work on them. And if you're doing that and you have, an issue that does come up, but you're able to demonstrate we're doing all the right things, we're doing what we need to do, then your annual limit has been reduced, because that's what the intention is, build a strong, robust program. So moving into the next section, with respect to some of the HIPAA exceptions that have been offered up as part of COVID-19. So I'll get into some of those. I know this is of interest for a lot of you on the line today, and kind of wondering how we can, how you can work through this troubling time. So we'll jump in with some of the changes or exceptions that we have in place right now from the OCR. On the next slide. So think about.
Thanks, Ryan. Yeah, sorry. Great. As Ryan introduced, there have been some exceptions that have been put in place due to the COVID-19 outbreak, and this was published back in March by HHS and OCR. So it's important to point out that these are not permanent waivers, and these exceptions may get revoked down the road. But let's go ahead and dive in, the first of which is telehealth exceptions. So HHS announced they are permitting exceptions for video conferencing where you don't have to worry about the, quote unquote, HIPAA compliant nature of video conferencing capabilities. It is still important to practice due diligence when you're evaluating these technologies. but they did issue some guidance on some examples that fall into these examples or into some of these exceptions, some of which include Apple FaceTime, Facebook Messenger, Skype, and Google Hangouts. So these are deemed as appropriate and waived for the near term to be acceptable to use. And the point here is to really enable collaboration without sanctioning in place. They did point out some technologies that are publicly facing applications that are not permitted, and those include Facebook Live, Twitch, and TikTok. So keep in mind there are some boundaries, and make sure you're following that guidance accordingly, and still practice security due diligence when possible. There are some exceptions around first responders as well, so police and EMS. You are allowed to share information on someone if they have COVID-19 on a case-by-case basis, and that is, the underlying objective is just to make sure that the first responders can take precautionary measures and protect themselves. You're not allowed to post a list of people who may have COVID-19 in your neighborhood or anything of that nature, so it's important to remember that it must be on a case-by-case or call-by-call basis. The remaining exceptions are really around the HIPAA privacy rule, and there's more guidance issued by HHS in a bulletin that goes into a lot more of these details. But the first one we'll talk about is consulting with family. So providers don't need a patient's consent to consult with family members about COVID situations. So providers can speak directly with family members without having to check with the patient first and get their consent. Next is the notice of privacy practices. So they did waive the requirement for the distribution of notice of privacy practices. So you don't actually have to provide a physical copy to patients during this time. Caveat being, you should still have your notice of privacy practices posted on your organization's website, but there is a temporary waiver for distributing that just for the current pandemic situation. The last of the waivers is around disaster area requirements. So HHS has issued guidance that says that these HIPAA waivers related to the privacy rule are only applicable to hospitals that are in locations that have declared a state of emergency or hospitals that have issued a disaster protocol. And these waivers that we mentioned, relating to consulting with family members and notice of privacy practices, these waivers can only be, they're only applicable for 72 hours once this disaster area requirement has been declared. So it's not a forever waiver and is meant to provide some temporary relief. Again, these waivers are temporary and they're intended to help organizations continue to operate given the current pandemic situation, and these waivers will not be permanent. We haven't heard communication on when these waivers will be revoked, but that is something that we're still monitoring. Okay. All right. So I know Ryan covered some of the penalty structures with you, but on these next slides, I really wanted to dig in deeper into the results from the OCR audits and lessons learned, and in turn, which pieces and findings ended up resulting in those civil monetary penalties. As Ryan mentioned, and it will continue to be a theme, is around a lack of an adequate enterprise-wide security risk analysis. This continues to show up as a common finding from the OCR audit results. You saw earlier in the presentation that a lot of the fines that have been issued stemmed from organizations not having conducted a risk analysis or practicing proper risk management. In fact, I'm sure a lot of you remember a key finding from OCR's breach investigation report on Anthem, which resulted in a $16 million fine, was the lack of an enterprise-wide risk analysis, along with some other components as well. Wanted to pause and just say that, I think some organizations may think that activities like conducting a SOC 2 examination will check the box for conducting a risk analysis, but it doesn't. A security risk analysis needs to have not only findings and recommendations, but also, that the likelihood of incurring a breach, what the impact to the organization will be, the maturity of that control and its operating effectiveness, as well as an associated risk rating for each finding. And we'll talk more about this when we get into the recommendations, but just wanted to put that out there now. The next bullet you'll see here is around the addressable provisions. I think there's if you're familiar with the HIPAA Security Rule, and I'm sure most of you are, there are required provisions and addressable provisions within the HIPAA Security Rule. And I think a common misconception is that addressable translates to optional, and that's not the case. Back in 2003, when the HIPAA Security Rule was first rolled out, there were addressable requirements around encryption and multi-factor authentication, and implementing those technologies were a little more complex and complicated and maybe not the norm, but OCR expects reasonable controls to be put in place, and endpoint encryption on your laptops and multi-factor authentication, especially for remote sessions, is a reasonable security control nowadays. So unless you have a very good business justification for why you're not meeting those addressable HIPAA requirements, then you're going to get into some hot water with the OCR if you do end up receiving an OCR letter. Regarding business associate agreements, many healthcare entities have BAA inventories that are out of date and inaccurate, which will cause issues during an OCR investigation. I know healthcare organizations must obtain BAs from third parties and require appropriate security and privacy safeguards, and then, periodically thereafter, continuing those evaluations to ensure third-party compliance. I get that managing third parties can be difficult and cumbersome to verify contractual compliance and ongoing oversight, but this is something that the OCR expects. And again, going back to some of the earlier slides, a lot of the breaches that were reported to HHS and are on that wall of shame are a result of a third party kind of being at the bottom of it. On a positive note, outsourcing certain third-party management activities to companies who perform this for many healthcare organizations has become more viable. And also, it may be more cost-effective to outsource this third-party assurance type activity more so than doing it in-house. Entities that do not report breaches. So breaches are more common today than ever. So organizations that do not report any breaches can still raise a red flag. So just because you didn't report any breaches to HHS does not mean you're off the hook. There's also the thinking on, did a breach not actually occur, or are there just not controls sophisticated enough to detect them? Or maybe, the required risk analysis processes are not in place to determine whether to declare a breach or not. So making sure your organization has something like a decision tree diagram in place to help conclude if an incident is just an incident or an actual reportable breach should be in place to help support your organization's incident management capabilities. And the bottom line is, even if your organization does not encounter a breach, you still need to be prepared to justify your controls and breach processes, because you still may get a letter from OCR. And the last bullet here on the slide is around the right to access compliance, and this is related to patients. So healthcare patients in the US have a right to access their medical records, and organizations have a regulatory requirement to provide them. And patients are becoming more savvy, they're more engaged in their health and wellness, and OCR wants to make sure that organizations are educated on their responsibilities and are able to provide patients with timely access to their records electronically and in the patient's preferred form and format. I'm continuing on with the OCR enforcement focus areas. The first step is just continued lack of technical and administrative safeguards. So administrative referring more to policies and procedures, and a lot of times this is just due to, a lack of them being in place at all, or, them being neglected for several years. And I know it's a big lift to go through and continue to review your policies and procedures. But one thing that, if you do receive an OCR letter, they will ask you for your security policies and procedures, and not just the most recent ones, but for the past 6 years of, your security policies and procedures. And I'll go over that again later on in the presentation. Other common vulnerabilities that the OCR notes are lacking include a lack of audit logging and monitoring. So there are still a lot of applications that host or process PHI that are not being properly monitored. So I think, organizations will do a good job at having monitoring in place, especially for their EHR systems, but there are ancillary systems that are still being neglected and showing up as, an area for improvement. Other technical pieces include inadequate software patching, especially for those vendor third-party systems, and also poor security practices around media disposal. There are still issues around organizations' use and disclosure more than the minimum necessary when it comes to PHI. So it's important that your organization is practicing the minimum necessary principle. And then lastly, and what I found actually surprising, is inadequate security and HIPAA training. So, some of these other more technical components, require more budget and implementing a technology, but, HIPAA security training isn't as heavy as a lift as implementing a new technology. So it's important that you're that you have training baked into your onboarding processes for new hires, and then are conducting HIPAA training on a periodic basis thereafter, recommendation there for it to be annually. Okay, so this is really one of the last slides we'll cover with you today during the presentation before we open it up for questions. So start thinking about what questions you have, and you can submit those through the chat. But getting into the recommendations, as I'm sure you've picked up on by now, there's a continued theme around risk assessments and risk analysis. And the recommendation is to perform a periodic, at least annually, security risk assessment and analysis on your organization's information security policies, procedures, and systems. Risk assessments and analysis activities are critical procedures to identify and prioritize any control weakness. And with proper prioritization and resource allocation, you can address identified weaknesses and ultimately improve the posture of your security program before the OCR comes knocking. And one way to kind of continue to perform that risk analysis and risk management activities is to have risk management tools, such as risk registers. So risk registers should really be built into your business processes. Corrective action plans are another term for a risk register. Over the past several years, OCR has specifically started terming this as a risk register. And if you do receive a letter, again, they're going to want to see your risk register. And the risk register provides you with a method of documenting each identifiable risk, event, or vulnerability point in your organization, including those with business associates. So making sure you have third-party assurance as a component baked into that overall risk analysis. It's important to note that this risk register is a living, breathing document document and is updated every time a new security risk is identified or a change occurs in your environment. So, you know, you might go through, perform an annual risk assessment, you've got your risk register, but you're not going and updating it until a year later. And that's not the intent of a risk register. Again, it's supposed to be a living, breathing document. And this regularly updated risk register provides OCR with evidence that a continual risk management program is in place and gives them that assurance that, you know, you're monitoring and have a handle and are working towards reducing your overall, you know, risk footprint. Lastly, the risk register should really include who is doing what and when. It also needs to include, again, the likelihood of incurring a breach, impact, the maturity, a finding recommendation, and associated date, just so it's you're able to track against it and there's a clearly assigned point of contact and remediation date. I mentioned that the OCR, if you do receive an OCR letter, that they will ask you for your past 6 years of policies. Some other tangible examples that, you know, as we've been involved with helping organizations respond to OCR letters, in addition to policies and procedures, they're also going to ask you for your latest risk analysis and may even go back to a period in time, you know, dating back 6 years, just to make sure that it's a continual process and not just a one-time check the box and, you know, put it on the shelf and don't really do anything with it. And also evidence of training records. So especially if you've had an incident or a breach where a person was involved, you better believe that the OCR is going to ask you for evidence of that person's HIPAA security training. Lastly, wanted to talk about considering going through a mock OCR audit. So either doing this internally or leveraging a third party to make sure that you're prepared and can adequately respond if you end up being selected for an actual OCR audit or receive a letter. The OCR audit protocol is published on the hhs.gov website. So you do have a starting point of knowing what the OCR will be looking for if they do come a-knocking. And remember, if you do receive a letter or get notified, you only have 10 days to respond to their request and provide evidence. So it's important to know where to go to be able to fulfill requests. And what I mean by that is, you know, having a repository of, you know, of course, where you keep your policies and procedures, but maybe having a type of repository where, you know, the common type of request that is in that OCR audit protocol guidance is kind of already pre-populated. So you're not, you know, running around like a chicken with your head cut off for 10 days trying to track everything down in that list. And, you know, I've seen those OCR letters have anywhere between 10 and 20 requests. So it can be a pretty heavy lift and pretty stressful to be able to respond and get everything that's being asked for within that 10-day period.
And there's some key, some additional key takeaways, I think, just to restate and you know, provide additional detail. But we've all heard the phrase, you know, it didn't happen if there's not a picture. And as, you know, as annoying as that is to hear sometimes, it does kind of hold true here in particular. And so, you know, in addition to operating your information security, your privacy, your programs, you know, and implementing the controls that you normally would implement, getting it down on paper, being able to demonstrate that it is actually happening and taking place is important. And I think the key tie back to the reason why the OCR changed the enforcement and the fines tiering. So here you're able to go ahead and benefit from that because you are, as Bethany said, not stacking the documents on the shelf, but keeping them alive and well and really working and running your program through that documentation.
Great, thanks, Ryan. Yeah, and ultimately a proactive program can reduce the likelihood of findings of willful neglect and ultimately reduce civil monetary penalties that may be imposed by the OCR. But that concludes our presentation for today. Thank you all for tuning in and listening. And now we will open it up for questions.
Wonderful. Thank you, Bethany, and thank you, Ryan. That was fantastic content. So now we're going to pivot on to the questions that were submitted during today's presentation. If you haven't had a chance to submit yours, please go ahead and submit them through the questions pane after GoToWebinar. So let's go ahead and get started. So here's one of our questions. If risk analysis is always the first thing the OCR cites and finds you for, why aren't there any examples of a risk analysis that will satisfy the OCR? The OCR confuses everyone by issuing the HIPAA Audit Protocol 2.0, which is fine for the evaluation and implementation specification, but not appropriate for risk analysis.
Yeah, I think, there's constant monitoring of the new guidance being released by the OCR. And there has been, guidance out there released by HHS that says, things like NIST 853 is an appropriate way to conduct a risk analysis. And I think it's important that, whatever framework your organization chooses, you have options, right? So whether you're going to use NIST 853 or NIST CSF or, high trust, I think it's important that you determine a framework and you have a methodology that encompasses some of what we talked about today. So you have knowledge of where all your PHI resides, that you do a enterprise-wide risk analysis and include some of those key controls that not only align back to the HIPAA Security Rule, but also follow that framework. So I think you just need to be able to justify to the OCR that we have a risk management plan. This is the framework that we're following, and providing evidence that you're continuing to monitor those controls and perform that risk analysis. But you're right, they don't say there's only one way to do that, but I think that's a good thing because you have some flexibility in deciding on how and what approach to take in your risk management capabilities.
Wonderful. Thank you, Bethany. So moving on along, do you think OCR will delay enforcement during the COVID crisis?
So I can jump in here. We've seen a little indication of a delay in maybe new enforcement, giving some necessary leeway to healthcare providers right now. However, ongoing enforcement is still kind of full steam ahead. So if there is a case that was actively being investigated or in the works, a lot of that stuff is still happening. In fact, and so that's important to note. I think we saw kind of a resolution even earlier this year. As far as current enforcement with, right now in healthcare, yeah, there's some leeway. I know Bethany spoke in detail about some of the leeway. But the point is, when everything's back to normal and a violation might have still occurred now, that can still be on the table for review. And I think the last part of this is the OCR is still doing proactive audits. Those are still kind of on the docket. If you're a business associate right now, that's also something you might not be in the provider space, but there's still active enforcement happening. So something to keep in mind. You don't want to relax your posture at this point. You want to keep doing the right things even through all of this, while taking the necessary leeway when you absolutely have to.
Okay, thank you. So moving on along, what security and compliance areas should healthcare providers prioritize during the COVID-19 while our organization is busy dealing with the crisis?
Yeah, that's a great question. I think, we're hearing a lot that, we have resource constraints. We're busy fighting fires with this pandemic. We don't have enough space, so security is kind of taken a back burner along with a lot of other things. So it's not just security, you have to consider patient health and continuing business operations, which is understandable. I think, as far as what security and compliance areas should still be focused on, still being able to do a security risk analysis, and maybe it's not a full-blown risk analysis. Maybe you just look at a subset of, your environment or a component of it, and then do, the remaining pieces, 6 months to a year later. But I think also maintaining focus on emerging attacks. The bad guys out there are, thrive in opportunities like these, as far as, COVID-related phishing scams and ransomware. So that being said, making sure that, you've got controls to protect phishing scams, and there's some training awareness activities that say, if you find a common phishing email that's sent out alerting your organization of, this is a scam, please don't respond to anything like this, or click the link. And then, to piggyback off of that, just doubling down on incident response preparation. How would your organization deal with a ransomware attack during COVID, for example? So those are just a few items that I'd recommend to prioritize while, busy dealing with this crisis.
I wanted to jump back and kind of clarify, my response earlier too. So with respect to enforcement, the proactive audits, so phase 1 and 2 audit type things, are not going on and ongoing. It's really active enforcement of cases. And then to piggyback off that last question, what are some things to focus on? I think one additional area is you're only as good as your vendors. And so, Bethany mentioned earlier, vendor management is a pain point. It's difficult to do. It's challenging. But looking at your resiliency of your vendors, and a lot of health systems have been impacted by vendors that were not able to function and work through the COVID environment that we're seeing right now. They weren't able to continue operations. And so something to review kind of now in post COVID-19 is who am I working with? Are they able to support me when I need them the most? So that's another important consideration.
Perfect. Okay, so I think we have time for one more question. So I heard Zoom and other video platforms have security issues. Is it safe to use them in healthcare settings? I know we kind of went over it, but I think it's probably a good idea to circle back over it again.
Yeah, great question. I know Zoom has been in the news and is, quickly trying to, put security measures in place. And, as mentioned previously, there are some exceptions that was issued, or some waivers rather, by HHS. But the short answer is yes. Zoom and other video platforms can be, it is safe as long as you configure them properly. Also, just a couple of days ago, OCR and NSA just put out some guidance this week. So I think I have it pulled up, but if anyone's interested, I can send the link in the chat. But they put out some guidance again 2 days ago. But you can also reach out to us, and we are happy to talk through it with you.
And then, just some more color here too. One of the things to note is, while it is permissible and it's been exempted right now to use these tools, it doesn't prevent you or exempt you from doing the necessary due diligence, even if it's after the fact. And so I know a lot of health systems have spun up new vendors, new technology offerings in the recent weeks. which is great. That's allowing them to provide the care that is needed. But the security teams, compliance teams should still, on the back end, or even concurrently, try to ascertain what some of the risks might be, document them. So going back to that living risk register, getting those on paper, and then, you know, if those technologies are continued past the COVID environment, that you get appropriate risk mitigation plans in place for them as necessary. So you know, that's another takeaway here. Yes, there's some exemptions, but it doesn't mean that you're exempted from doing your due diligence and your documentation.
Great, thank you, Ryan. So we're going to go ahead and close out this session today. So again, thank you, Ryan, and thank you, Bethany, and thank you everyone for attending. So happy to have you. If you have any questions that we weren't able to address, please feel free to reach out to Ryan and Bethany through the contact information that is currently provided on the screen. Again, each of you will be receiving a follow-up email with the link to view a recording of today's session. Just before you close out, Ryan, Bethany, anything else you'd like to add?
No, thank you, Kayla. Thank you, everyone, for joining. It's been great. And yeah, Ryan, anything else?
I just appreciate everyone's time today. I know we're all preoccupied with other things, but this is a really important topic to us, and I'm sure all of you on the line. So have a very nice weekend, everyone.
Thank you. So on behalf of MEDITOLOGY Services, the Minnesota HIMSS chapter in Trinidad, thank you much for joining and enjoy the rest of your day. Bye-bye.